Good evening and welcome to the Centenary webinar series. Tonight we have short paper session 4. My name is Christian Makutovic. I'm the director of the scientific program for the ASGBI. I'm joined this evening by Cleo Kennington, who's a consultant surgeon at St George's. Tonight we have a selection of papers in the general category, and the first person will be James Lucock, who is going to talk to us about non-visible hematuria requiring urgent assessment. Over to you, James.
Hello everyone, my name is James Luco. I'm a FY2 in NHS Tayside. My presentation is titled, Does Non-Visible Hematuria Require Urgent Assessment? A retrospective cohort study from a university teaching hospital. So next slide, please. So non-visible hematuria, or NVH, has a prevalence of about 2.5% in the general population. The urological malignancy is a main concern in NVH patients. The positive predictive value of NVH in bladder cancer alone ranges from about 1.6 to 4.8% in the UK. The NICE NVH guideline in 2015 advises patients over the age of 60 with either dysuria or raised white cell count undergo urgent investigation. Prioritization of high-risk patients is very important to ensure urgent investigation, as well as to prevent overwhelming utilization of urology services. The primary aim of our study was to identify high-risk groups who require urgent investigation. Next slide, please. So in our study, in our study, the definition of NVH was a positive urine dipstick with 3 pluses of blood on 2 consecutive urine samples, 1 to 2 weeks apart, after excluding a urinary tract infection. Our NVH assessment protocol included a history, examination, digital rectal examination, if applicable, renal function tests, full blood count, ultrasound, and also flexible cystoscopy. All adult patients with NVH referred from primary care practitioners between 2017 and 2020 were included. Patients were split up into malignant and non-malignant groups based on their diagnosis and risk factor compared. Statistical tests used included multivariate logistic regression and chi-squared analysis. There were 436 patients. Malignant and benign pathologies were found in 5.5% and 45% of cases respectively. In the univariate analysis, male sex, age above 60, smoking, and anticoagulation were associated with malignancy. Lower urinary tract infection symptoms were not actually associated with malignancy, and dysuria wasn't associated with malignancy. In the multivariate analysis, male sex, age above 65, and smoking were associated with malignancy, and in all of these 3 cases, the odds ratio was above 2.72. Next slide, please. So in conclusion, the positive predictive value of non-visible hematuria is significant. Lower urinary tract symptoms and dysuria were not found to be associated with malignancy, and our findings did not support the NICE 2015 NVH guideline. Male sex, age over 65, and smoking was associated with malignancy, and these patients should undergo urgent investigation within a 2-week period. Low-risk groups should continue to undergo investigation on a routine basis. Thank you very much.
Christian, you're muted.
Thank you very much, James. That was interesting findings. In terms of the low-risk groups, if you institute your new parameters for urgent assessment, do you know how many cancers you might miss or delay the diagnosis in the low-risk group?
So out of the 436 patients, we probably had about 25 cancers, and I think 1 or 2 didn't have any of those 3 main risk factors at all. I certainly think that at least targeting some high-risk groups is better than just not investigating NVH entirely, and that's what Denmark have done since 2015. They've just completely not investigated NVH at all. So I think some still will be missed.
And I noticed that the amount of investigations is quite extreme. It was quite consuming in terms of ultrasound, flexible cystoscopy, and CT. Have you looked at whether you can drop one of those more modalities, i.e., ultrasound?
Well, I guess the one you definitely need is flexible cystoscopy, because the majority of all the malignancy was bladder cancer, and obviously ultrasound and CT are far from being the gold standard in those cases. Obviously, if you excluded ultrasound, you have to have one sort of imaging to look at upper urinary tract cause if you were to investigate NVH.
Okay, very good. Thank you very much.
Thank you.
Okay, so our next presentation is from Thijs Mindersoen Tweed, so I hope I get your name right, and who's going to present today on laparoscopic surgery and is it protective against post-operative complications for sarcopenic patients.
Yes, thank you for the introduction. My name is Thijs Mindersoen Tweed. I'm PhD, MD, PhD candidate, and on behalf of my fellow colleagues, and I would like to present this study to you, laparoscopic surgery as protective against the development of post-operative complications in sarcopenic patients with colorectal cancer. Next slide, please. So sarcopenia is one of the most important risk factors for developing post-operative complications. This has been mainly described in open surgery. However, more and more patients undergo laparoscopic surgery due to its known benefits of colorectal cancer. We've included patients who received the laparoscopic surgery and open surgery during 2013 and 2018. And the muscle mass was determined on a preoperative computer CT scan at the level of L3, and this was corrected for the length. The objective of this study was to assess the association between sarcopenia and the complications after laparoscopic surgery versus surgery. Basically, the idea is we want to know, is laparoscopic surgery protected for for colorectal cancer patients who are sarcopenic? Yes, right. Next slide, please. So we report a total of 1,377 patients. In total, 420 patients underwent open surgery and 957 patients were operated laparoscopically. What you see here in the primary outcome, when it came to severe complications rated as Cleveland-Dindo throughout within 30 days, there were more complications, severe complications in the open group compared to those patients who were operated laparoscopically. It was 24.3% to 11.7%. And we also conducted a multivariable analysis, which showed that open surgery was a risk factor for developing severe post-operative complications compared to laparoscopic surgery. That was a very significant finding. Other significant risk factors were male gender, and an independent risk factor was also the Charleston Comorbidity Index, 7 and above. Sarcopenia was also found to be an independent risk factor for developing severe post-operative complications. And this was corrected for age, BMI, urgency, stoma placement, type of anastomosis, surgical abdominal history, and all of these were found to be non-significant. Next slide, please. So when we wanted to zoom in and focus on solely the patients who were found to be sarcopenic, and when looking at these patients, sarcopenia was found to be an independent risk factor for postoperative complications in the open group, but not in the laparoscopic group. And this was also corrected for age, urgency, BMI, stoma placement, type of anastomosis, surgical abdominal history, and all were found to be non-significant. So from this, we can conclude that sarcopenia is definitely a risk factor for the development of severe postoperative complications in open surgery, but not in laparoscopic surgery for patients with colorectal cancer. And patients with sarcopenia, therefore, seem to benefit more from the laparoscopic approach compared to the open approach. Thank you very much.
Thank you for an interesting presentation. The only thing didn't quite hear what you were saying at the beginning, but could there be, how did the patients, were they allocated between laparoscopic and open surgery? And could there be a factor relating to that has an impact on whether or not the patient is sarcopenic in those groups?
So,
is there a confounding factor that made a more sarcopenic patient more likely to have open surgery?
So these patients, they were included consecutively. It was not a randomized control study. They were included consecutively, and based on surgical preference of the surgeon and or in with the patient itself, what they would rather prefer or have based on the patient's comorbidity, they would go for laparoscopy or open surgery. So we could not. We did correct for type of surgery, and that was also found to be non-significant. So for type of surgery, yes, you found a difference between open and laparoscopic, but in order to minimize the bias, the selection bias, that we were not able to do that.
Okay, very good. Thank you.
Yes.
Christian?
Okay, great. So the next participant is Scott McDonald, who's going to talk to us about stoma attraction and how fat one is. Over to you, Scott.
Yeah, thanks very much. So my name is Scott McDonald. I'm one of the ST1s in general surgery working in NHS Lancashire in Scotland. And today, like we said, I'm going to be talking about stoma attraction and abdominal wall fatness. So next slide, please. So we're talking about stoma attraction today, which is a very common complication of stoma formation, affecting up to 1 in 4 of every stoma that's formed. Stoma attraction essentially occurs when the stoma is formed below the level of the skin. This can really affect patients, giving them quite a high morbidity and low quality of life, mostly due to leakage of effluent, causing skin excoriation, poorly fitting stoma bags, and leakage overnight, which can really affect their quality of life. It's previously been shown that higher BMI has been related to stoma attraction, but BMI, as we know, is a surrogate marker of body fat, has its issues. It tends to underestimate BMI in the frail patients and overestimate in the more muscular patients. So what we wanted to do is to demonstrate the relationship between true anterior abdominal wall fat thickness as measured on CT scan and any post-operative stoma attraction. Next slide, please. So the way we went about doing this is we went and done a retrospective stoma database review in a Lancashire District General Hospital over the period of 5 years. We identified any patient who had a stoma formed during that period, and the total patients were 172. What we done was we used the perioperative CT scans, which were available for 98% of these patients, and measured the anterior abdominal wall fat at 4 separate levels across the anterior abdominal wall, and these levels corresponded to the vertebrae between L2 and L5. Just to kind of demonstrate intraoperatively what we were doing radiologically, down in the bottom left, we're measuring the anterior abdominal wall fat at vertebral level L4, roughly between the ACES and the umbilicus, and in the bottom right, we're measuring it between the just above the umbilicus, so it's roughly the vertebral level L2, and you can see that there's less fat above the umbilicus than there is below. So we documented this, the median of these numbers, and compared it to the stoma attraction status, which was documented by trained stoma nurses and at 1 year follow-up periods. Next slide, please. So what do we find? So we had 169 patients, and in keeping with the previous literature, we found that 1 in 5 of our patients had stoma attraction, so it's a common complication. In those who developed retraction, we found the median anterior abdominal wall fat thickness was 25 millimeters, compared to those who did not develop retraction, in whom it was 19 millimeters. So a statistically significant difference between these two groups. And we also found, as demonstrated in the previous intraoperative images, that anterior abdominal wall fat thickness increases with descending vertebral levels. So essentially, you get less fat up in your upper abdomen than you do in your lower abdomen. So where does this lead us? It's a very common complication, like we were saying. We've shown that true anterior abdominal wall fat thickness is associated with stoma retraction. So therefore, we propose using these quick and easy and validated CT measures to pre-operatively plan where the stoma is to be placed, and we've started to institute this in our hospital with the stoma nurses. Thank you very much, and if there's any questions, I'm happy to take them.
Thanks a lot, Scott. I really enjoyed that. And I guess the findings are not that surprising, given that the stoma formation will be harder in the more obese people. In terms of consenting your patients, do you think there's a role here for measuring the fat on CT and giving a patient a percentage chance of retraction on when you're consenting them?
Yeah, I think that's a very good point, to be fair. And I think dealing with overweight or obese patients is certainly going to be something that we're seeing more of in years to come. And I think it's good to be frank about these things and say, because you've got a bit more fat in your abdomen, the stoma, this formation might be more difficult, so you're at more risk of retracting. I think that's a very good point, and it's something that should be talked about openly and used in pre-operative counselling.
Very good. Let's just see if there are any other questions. From Ian Anderson, from the president himself. Is this going to change your technique?
It will change the planning and the formation of where the stoma goes. The technique will be the same. I suppose you have to get more length for a more obese patient to try and prevent this in the first instance. So I suppose it's changing technique in that sense. It's changing the planning and ensuring that you've got enough length in the stoma, which should be done anyway.
Yep, I agree. Very good. Over to you, Cleo.
I think Kareem, has he made it on yet? I think we might need to come back to him at the end.
Yeah, can we come back to him at the end? He's logged on as an attendee and we're trying to fix him, sort him out at the moment.
No problem.
So then we'll move on to Sharif Mahdi, who's going to talk about informed consent for inguinal hernia repair and has the Montgomery versus Lanarkshire case changed practice.
Hello, my name is Sharif Mahdi. I'm an F1 doctor from the Lister Hospital in Stevenage in Hertfordshire, and I'm presenting on informed consent for inguinal hernia repair and whether the Montgomery versus Lanarkshire case has changed practice. Next slide, please. So we know that consent process, when correctly performed, guards against the risk of medical legal litigation. And the Montgomery versus Lanarkshire case in 2015 was basically a landmark case, and it determined a new era for consent practice. We moved away from, subsequent to the case, we moved away from a paternalistic approach to consent process, whereby we used to look at the reasonable body of medical opinion, to a redefinition of the standards about disclosure and informed consent. Inguinal hernia repair specifically can potentially result in significant long-term morbidity. And the aim of this study was to assess the quality of informed consent and whether standards have improved over a 10-year period. So we looked at notes, so it's a retrospective study, so we looked at notes from 2009 and 2019, so across the 2015 decision. 50 patients from those periods, from each period, over a 6-month period from 2009 and 6-month period from 2019. We assessed two things mainly, so the pre-operative clinic letters, and we assessed for whether the patient, whether it was documented that patient was offered an alternative option, such as conservative management, or whether operative risks were explained, whether more information was offered to the patient at that point, including leaflets or electronic information. But we also looked at consent forms, and we assessed them for whether they documented the intended benefits and the operative risks specifically. Next slide, please. So this table is quite busy, this slide, but I'll sort of walk through it. So essentially, if we look at the left-hand side of the screen first on the clinic letters, you can see that in 2009 and in 2019, there's sort of a small percentage of notes or patients who had hernia operation were explained the risks, or at least the documentation of risks was on the paper or on the clinic letter. And specifically, we look at chronic pain. And the reason I highlight chronic pain is because it's a high, it's got a high percentage of risk in people who have hernia operations. In some studies, it's in 10 to 12 patients, and it can be severe in 1 to 3% of patients. And so essentially that was improved a little bit from 2009 to 2019, but it still sits at 42% of patients were told about chronic pain as a risk when they were first presenting from GP. And then we looked at consent forms as well, and you look at the right-hand side, chronic pain increased, chronic pain explanation as a risk on the consent form increased from 48 to 96%. So that's a significant increase. And we showed that in our study that we are shortly going to be publishing in the Royal College of Surgeons Annals. And the other risks as well have shown some increase, but again, not really a huge increase between all of them. As to be expected, infection, bleeding were usually well documented, but other things not really. Next slide, please. So in conclusion, overall, we've shown that the documentation of risks of a pretty common procedure in the UK and the world was poor in 2009. There's been some improvement in some aspects in from 2009 to 2019. But essentially, because of the Montgomery ruling, we have to explain things that could happen, anything that could happen which is reasonable to a patient, and we have to make sure that's documented. And I think despite improvements in the consent form documentation, we still need to apply that in the outpatient environment. The Royal College of Surgeons have a document, which is, I've put that picture in the bottom right-hand corner, about supported decision-making. It has a quote from there: "The process of consent should begin well in advance of treatment." So at the first point of contact with the patient, informing them about the risks of the procedure, all the risks. And I think that's why we decided to do the study, because we thought it was interesting, and that's what we've shown. But obviously the hope is that other centres do that, and maybe there's more sort of collaborative future research about it. Thank you very much. Take any questions.
Thank you. It's really interesting, and it's good to show how much your performance has improved, especially on the consent form. And you have kind of answered my question already with those high levels on the consent form. But I wonder, given that although the improvement is only to about 20% in some of the factors from the pre-operative findings from the clinic letter, what do you think can be done to try and improve that further? It's been 5 years now since that landmark case, what should be done to make those improvements more dramatic?
Sorry, I had it on mute. I think different people have come up with different things. You know, some of the things we thought about was whether we can sort of have a standardized sort of checklist when you go through certain procedures. But then again, that can come to might not cover everything. It might not be sort of suitable for a particular clinician or the sort of patient-doctor relationship. I think different people have said something about electronic information, so having the information available for the patient. So yes, you discuss all the risks or the possible risks and you quote percentages, but you also, patients won't remember that, or they might not remember that. So you give them that information through a link, through a leaflet. I think that would help things.
Question from the floor here, Cleo says, it's an anonymous attendee. Are your risks typed in a consent form as standard? So do you have a standardized inguinal hernia consent form?
You mean at our centre? No, we do not. So we sort of obviously grouped different people use slightly different terms. Obviously terminology can differ slightly, but we tried to group things into those categories that I had in the table, so that we could present them. But no, we don't have a standardized way. That's a good idea actually.
So lots of centres do that for major resections. I've got one final question from Duncan Rutherford, who says, did you explore how many patients received a copy of their consent forms?
No, we didn't, and that's something that we should be doing. That's a really, really good idea, and something we're looking to for future projects.
Very good.
Okay.
Thank you.
So moving on, Christian.
Next. We get on the next one. Okay. So now we are moving on to Mani Agahosseini, who's going to talk to us about the anatomical and physiological analysis with domain loss in abdominal wall reconstruction. It's a really interesting topic. Over to you, Mani.
Thanks very much. So yeah, my name's Mani Agahosseini. I'm a medical student from the Holyoke Medical School, and I'm going to talk to you about the abdominal wall, different strategies available to deal with abdominal wall reconstruction with loss of domain. Next slide, please. So this was sort of done as part of a master's thesis that I'd done. And basically it was looking at, the main aim was to compare and analyze the three most prominent abdominal wall expanding techniques, PPP, Botox, and component separation. And what I did was look at the physiological and anatomical effects that these techniques would have on the abdominal and thoracic cavity. And so in order to do this, I had to conduct a literature search and compare quite a few papers. And on the right, you can see the sort of process that I went through to compare these papers, go from about 116 papers down to about 30 full text that ended up going up for the full review. Next slide, please. So in terms of the results, I sort of separated it into the three strategies. In Botox, there was about 120 patients, and the fascial closure rate here was 97%. The doses ranged from study to study, from 200 to about 500 units. Also, the time period between Botox administration and to the surgery being completed had varied from study to study between about 1 to 4 weeks. In terms of PPP, it was 247 patients in total, and that reported an average of 98.3% fascial closure rate. 3 studies actually did look at the respiratory mechanics when PPP was involved, and 2 papers actually reported an improvement in respiratory function tests, so vital capacity and forced expiratory volume. The different gases used included NO2, CO2, and sort of ambient air as well. For component separation, it included both posterior and anterior component separation, and there was about 127 patients here with a 97% fascial closure rate. But when you separate the two between anterior and posterior, it's quite obvious that posterior had much lower rates of complications, lower rates of hernia occurrence, and a greater fascial closure. Next slide, please. So in terms of what this sort of meant, Botox and posterior component separation came out on top with the results, sort of lower recurrence, lower complications, and greater fascial closure. In terms of the procedural sort of like optimization, Botox, the optimal dose I found was about 300 units. So using any more than 300 units of Botox wouldn't increase the abdominal wall length any further, but obviously can increase the chances of further complications or problems. In terms of the time period, 10 days was the period long enough for Botox to relax the abdominal wall muscles. So some studies were waiting 4 weeks between administering Botox and surgery, but that seems unnecessary. 10 days seems to be long enough. The best practice for PPP, it was like an ambient air micropore filter, and this was done in insufflation sessions every 2 to 3 days for about 15 days. And in that study, patients averaged about 6 liters in total of gas in the abdomen, and their results were much better in terms of lower complications compared to some studies where the average was about 11 liters and sort of spread over 4 weeks. And just a quick point about the last point there about reviewing how success is measured. When I was comparing all these papers and techniques, they were kind of measuring success based purely on fascial closure. But to me, it didn't make sense sometimes when obviously it's a successful closure and then 2 weeks later the patient come in with a hernia recurrence or a complication. And also, I think an important part that wasn't mentioned in any of the studies really was abdominal function. I feel like when you undergo a surgery and you come out of there, to have some sort of function remaining is very important. I think there's like sort of fundamental principles you sort of need to measure your success against purely the fascial closure that some studies were doing. Thank you very much.
Thanks a lot, Mani. We've got Professor Anderson saying here, very nice presentation. He may have missed it, but how long was the average follow-up?
For each study that I compared had different levels of follow-up, but the minimum was 3 months. Every study that I looked at did have a minimum of 3 months. Some varied from 3 months to about, I think some follow-ups of about 2 years.
Did you get any sense of what technical factors led to failure of closure and what patient factors led to failure of closure?
It was again, there was quite a few papers to sort of talk about, but I think the majority of the time it was comorbidities, or some papers that were looking at patients sort of in sort of worser conditions, sort of it wasn't an elective surgery as such. It may have been sort of an emergency surgery within like 24 to 48 hours. In terms of specific problems related to any of the strategies, I don't think I can remember coming across any particular ones.
Okay.
So I've got one quick question. Was there any information about the patient satisfaction with the methods? I don't know, I can imagine having air pumped into me might not be very pleasant, and how does that compare with the different?
It's quite interesting actually. All the PPP, obviously, it varied. Some, as Ed mentioned, about some of them were just like 15 days long, and every 2 to 3 days, but some were over a month long, or for like 3 to 4 weeks long, and patients having to come in every other day for having that. It was not just uncomfortable, but obviously getting to the hospital, being monitored and coming back, and then and patients, obviously, quite a few of them had comorbidities anyway, so it wasn't such an ideal situation. And then you compare it to Botox, where it's a simple few injections, and then you come in for the surgery. There was no official sort of survey, but I think just thinking about the sort of logistics of it, I can imagine Botox was a much popular procedure than the PPP.
Sure it is.
Okay, so now we're going to go back to Kareem, who had trouble getting into the webinar earlier on. So Kareem El-Sayi is going to talk about post-colonoscopy colorectal cancer and a review, I've lost it, of colorectal cancer diagnosed by colonoscopy in York Teaching Hospital.
Good evening, everyone. My name is Kareem El-Sayi, and I'm presenting this short paper presentation on post-colonoscopy colorectal cancer for patients who were diagnosed with this in 2018 at York Teaching Hospital. Next slide, please. So post-colonoscopy colorectal cancer, known as PCCRC, is any colorectal cancer which was diagnosed after having a negative colonoscopy. And this is quite an important subject that has been under investigation and by endoscopists and an endoscopy unit over the last few years. And there was a consensus article from World Endoscopy Organization which set out all the definition and criteria in order to be able to label a diagnosed colorectal cancer as MIST 1. And it measured the rate over a period of between 6 to 36 months from diagnosis. The aim of this study was to look into all patients diagnosed with colorectal cancer in 2018 in York Hospital and see whether they have possible missed colonoscopy previously, and to look what are the causes in order to try to rectify it in the future. We looked in the MDT register for all colorectal cancer in 2018, and that was in total 313. 238 patients were identified as true colorectal cancer after exclusion of some repeated entries and miscoded and small bowel cancer and non-colorectal recurrence. We followed the root cause analysis suggested in the consensus article from the World Endoscopy Organization in order to detect what were the causes of failure. Next slide, please. In the first graph, it looks to the 313 patients with the exclusion of those who were irrelevant. While graph number 2, it looks at the 238 patients where 168 were diagnosed by colonoscopy, and the rest, which are 70, were diagnosed by CT. In total, there were only 8 patients who were found to be PCCRC, making the rate around 4.5%. Site of missed cancer were 4 patients in the rectosigmoid, 2 in the transverse colon, and 1 in each the hepatic flexure and the ascending colon. By analyzing the root cause analysis, male to female ratio was 6:2, and the mean colonoscopy withdrawal time was 8 minutes. Bowel preparation was good in 5 patients, while only adequate in 3. 7 out of 8 patients, they already had a planned surveillance when this PCRC was detected. Next slide, please. As a conclusion, we found that York Teaching Hospital in 2018 had a low PCRC rate of 4.5 compared to the nation, which was 8.2. Plan was to emphasize on the need of improving the bowel preparation and increasing withdrawal time to decrease the rate of PCRC. Just for a future plan, which is already in action, we have started to look at the data from 2015 till 2019 as 5 years worth data to look and identify causes of PCRC in these patients. Thank you very much.
Very interesting presentation. What do you think it was the reason why your rates were so low compared to the national rate of 8%? You have half of normal. What do you think it is that you do well in York?
Well, at first, there has been quite a lot of changes in York in terms of endoscopy unit. In 2018, mainly all endoscopies were carried out by consultants. And I think that has decreased the rate of PCCRC. Also, there was, in terms of the training, there was not enough training for juniors. And I guess that is an important element as well, because if you are thinking that a well-trained consultant is doing this procedure, there is less risk of missing a cancer.
And did you find that the ones that were PCCRC, did you find that they were more advanced, or the fact that they'd been missed for up to 3 years, did that have a bad effect on the patient?
Not really. Maybe 2 of them, one of them actually, he was presented with advanced cancer, but the rest of the 7, they were having just a small cancer in different places as were found, the retrosigmoid and the transverse colon and the hepatic flexion.
So the delay didn't cause them any harm?
No.
Okay, great. That's brilliant. Thank you.
Thank you very much.
There's no other questions on the chat that you just answered the last one.
Yeah.
So we move on to our talking posters. Vic, have we got Young Yoon here?
Yeah, I'm here.
There you are. Hello. So welcome. Over to you.
Sure. Hello, my name is Won Young Yoon, and I'm a medical student at the University of Manchester. And today I'll be presenting a study on the correlation between the number of sentinel lymph nodes and the incidence of micrometastases. So to begin with, sentinel lymph node biopsy is a technique that identifies micrometastases within lymph nodes in the regional nodal basin. And it's useful in the accurate staging of tumors, such as skin malignancies, because of its reliable pattern of lymphatic drainage. And Breslow thickness, ulceration, mitotic rate are some of the well-known prognostic factors for melanoma, of which Breslow thickness is the most accurate. And our study aimed to investigate whether there is a correlation between the number of sentinel lymph nodes harvested at the time of surgery and the incidence of micrometastases. And we conducted a retrospective review of the records of patients who underwent sentinel lymph node biopsy at the Christie Hospital, Manchester from April 2008 to May 2019. And a positive sentinel lymph node was regarded as a node with measurable micrometastases through immunohistochemical staining with S100 and melanate. Of 1,688 patients identified over the study period, 1,158 patients had sentinel lymph node biopsy of the limbs and trunk. And there were 742 patients with 743 primary melanomas of the limbs, and 416 patients with 416 primary melanomas of the trunk. And a total of 10 patients were excluded from the study as they met one of the exclusion criteria. And in this study, we have found that there is an increase in the incidence of micrometastases with an increase in the number of sentinel lymph nodes removed at the time of surgery. We can see this in Table 1 and in Figure 1 for the limbs, and in Table 2 and in Figure 2 for the limbs and trunks. And Breslow thickness is usually regarded as the single most important prognostic factor for clinically localized primary melanoma. And in order to establish the number of sentinel lymph nodes harvested at the time of surgery as an independent prognostic factor, we have looked at the correlation between Breslow thickness and the number of sentinel lymph nodes harvested from the limbs and trunks. And as you can see in figure 3, we have found no direct correlation. The average number of sentinel lymph nodes harvested at surgery was approximately 2 nodes for all Breslow thicknesses. And as we would expect, there was a direct correlation between Breslow thickness and the incidence of micrometastases. As you can see in figure 4, for tumors with Breslow thicknesses of 0 to 3.99 millimeters, there was a progressive increase in the average percentage of micrometastases. And this means that high-risk melanomas do not influence the number of sentinel lymph nodes harvested, but the number of sentinel lymph nodes harvested increases the risk of micrometastases. And one of the strengths of this study was that it was conducted in a single busy tertiary melanoma center over a relatively long ascertainment period of 10 years. And however, we regard this as a pilot study and hope to extend it to multiple centers in order to increase patient numbers. And as part of our future works, we hope to look at patient survival data and other prognostic factors. In conclusion, our findings indicate that there is a direct correlation between the number of sentinel lymph nodes harvested at the time of surgery and the incidence of micrometastases in patients with cutaneous melanoma. Thank you very much.
Thank you very much, Juan. Just a quick question for you. How has this result changed what you do in theatre? Are you taking more sentinel lymph nodes routinely?
So this study was conducted in December of 2019. And basically, the plastic surgery department at the Christie Hospital decided to extend the study to other centers. So nothing has changed at the moment, but we are collecting data so that we have a stronger evidence base.
Very good.
Okay, so moving on, the next poster is presented by Luke Zhu, and he's looking into why do day surgery patients stay the night.
Hi, my name's Luke, and I'm a fourth-year medical student at the University of Glasgow. And the title of my talk is "Why do day surgery patients stay the night?" This is an audit into the day surgery service for laparoscopic cholecystectomies and inguinal hernia repairs at a district general hospital. In the Audit Commission's first value for money report, it suggested that if all health boards in the UK performed day surgery at achievable levels for the 20 most common procedures, then 186,000 more patients could be treated each year without an increase in spending. Over 15 years ago, the government introduced 10 targets for a modernising NHS, and number 1 on that list was to treat day surgery as the norm for elective surgery, with the underpinning goal to design a healthcare system so that the only time patients spend in hospital is the time which adds value for them. And we found that there were anecdotal reports from staff who felt that too many patients were being admitted following day surgery procedures. And this study aimed to reveal exactly what this figure was, to find the reasons why patients were admitted and suggest potential changes to the day surgery pathway. We conducted a retrospective cohort control study for all laparoscopic cholecystectomies and inguinal hernia repairs booked as a day case procedure carried out between the 1st of October 2018 and the 31st of September 2019. We included a total of 283 consecutive procedures, of which 199 were laparoscopic cholecystectomies and 84 inguinal hernia repairs. Patients admitted had a mean age of 54.8 years, with 51% of these being female. Procedures resulted in an overnight admission in 55.5% of cases, with this admission lasting 1 day for 45% of all procedures. After analysis, it was found that the patients who were admitted were more likely to be older at 57 years of age compared to 52, and were more likely to be female, with 57% of those being admitted being female compared to 42% of those that were not. We found pain and late recovery to be the 2 main factors preventing same-day discharge. And we also found that timing of surgery was a crucial factor in deciding whether patients were admitted. 63% of patients with surgeries which began after 1 p.m. Were admitted, compared to only 29% of those who had surgeries in the morning. And we had a few suggestions for this difference. Patients operated on in the afternoon may have had insufficient time to allow for adequate recovery associated with pain, the lasting effects of anesthetics, and a delay in passing urine. And prolonged fasting and dehydration were also potential factors. And we suggest a few changes that can be made to the day surgery service, including education surrounding a criteria-based rather than time-based discharge, post-operative urinary retention policy allowing patients to be discharged home without having passed urine, with instructions to reattend if they do not, a sip until we send fasting policy to encourage hydration and reduce post-operative nausea, and additional list review to prioritize patients who are identified as more likely to require admission. Thanks very much.
This is a great presentation, and I think you answered my question, because I was going to ask you what you could do to reduce those overnight stays, but you've already come up with a great answer. So
I've got a question. I really enjoyed that, Luke. It's something that it happens a lot in my hospital. I can't get down to what makes patients stay. Do you think there are cultural elements that have an impact on whether patients expect to stay overnight or not?
Yeah, potentially. I think the idea of going home on the same day as your surgery without staying overnight, being watched by doctors, can be a bit concerning if you're the patient, I suppose, if you're more used to the maybe like more old-fashioned way of staying in hospital as a guarantee of having good care. But I think the way that patients are being risk stratified and the patients who get selected for day surgery and the evidence behind day surgery suggests that there's nothing that patients should be worried about, and it's probably important to convey that to them.
So do you think we need to just get better at reassuring them pre-operatively that that's what normal is, to go home on the day?
Yeah, definitely. I think that would definitely contribute to patients feeling a bit more reassured.
Great.
Thank you.
Okay, next we have Mikhail.
Okay. Good evening, dear colleagues. My name is Mikhail Kruszynowski. I'm an SHO working in South Tyneside District Hospital, and I'd like to present the audit about preoperative coagulation screening in elective surgery. So the audit standard used in this study was NICE guideline number 45, published in 2016, and it divides all elective surgeries into minor, intermediate, and major. The scope of our study was intermediate surgeries, and for this type of surgeries, NICE guideline 45 recommends pre-op coagulation screen only in case of history of chronic liver disease or anticoagulant use in patients with ASA grade 3 or 4. So the objective of the study was very simple: to check if we're following this recommendation. Methods. 3 months data was collected from a prospectively maintained database from our electronic health record system called Meditech. And you can see in the methods section the parameters that were collected. They are ASA grade, type of surgery, history of chronic liver disease, history of anticoagulant use, preoperative coagulation results, and bleeding-related complications. And here are the results. None underwent elective intermediate surgery. None had chronic liver disease, and 9 patients were on anticoagulants. And table 1, I apologize for small slides, it shows the types of surgeries performed. It basically ranges from inguinal hernia repair and lap chole and to groin exploration and biopsy. In table 2, you can see the ASA grades of the patients. Basically, 30 patients were ASA grade 1, 54 ASA grade 2, and 13 ASA grade 3. And we found that the compliance with NICE guidelines was 46.4%. And actually, the major reason for non-compliance, it is enclosed in the box in table 2. So the major reason for non-compliance was overuse of preoperative coagulation screenings. In other words, it was indicated, but it was not indicated, but it had been done. Moreover, in none of the cases, abnormal results were clinically significant or led to change in management. We had only 1 patient who had preoperative coagulation screen normal, who was readmitted with postoperative bleeding and required pressure dressing. So in the conclusion, I would like to say that there was an overuse of preoperative coagulation screening in our institution, and it resulted in small additional cost without clinical benefit. The cost of one test is £4.64. So the potential benefit of reducing unnecessary screening is almost £1,000 per year. And thank you for your attention.
Very good. That's really interesting. Thank you, Mikhail. So what have you done to change the practice in your hospital? How are you disseminating what should happen as per the NICE guidelines? Because we overdo coagulation screens in my hospital. Right. So where do you think we should be educating people?
So I think the most important point, what we did actually, and we're planning to do the second loop of the audit, we actually raised the awareness of the nurses working in pre-assessment clinics, because I mean, apparently they should be aware about the guidelines, otherwise they're going to be kind of continuing to err on the side of caution and continuing doing tests which don't change clinical management.
Very good. That's what we found as well. Any other questions? No. Over to you, Cleo.
Okay, so next presentation is on surgery for rectal prolapse. What is the gold standard, by Oladir and Olatunbodi. Is he here? Are you on? You're on mute, Olatin.
Sorry about that. My name is Kieran Olatunbodi. I'm a surgical registrar in the Northern Deanery at Dramescook Hospital, and I did this part of the plenary works on a master's dissertation looking at rectal prolapse and what the gold standard is for surgery. Rectal prolapse is not uncommon and can be a problem that causes affects the quality of life of patients. Usually there is a problem with the pelvic floor, and it could be associated with prolapse of other pelvic floor structures. Treatment could be conservative or surgical, and when surgery is indicated, there are quite a number of options, which could be perineal options like the lungs or ultimates, and transabdominal options like suture rectopexy, mesh rectopexy, or resection rectopexy. The choice of surgery usually depends on the skill of the surgeon, as there's no gold standard or agreed guideline. So we wanted to look at surgical options available and see if any had the best surgical or functional outcomes. The literature review was performed, and amongst the various options, the laparoscopic ventral mesh rectopexy is emerging as the surgical intervention of choice. Recurrent rates have improved, and postoperative recovery is better. When it's compared with like a robotic option, it's cheaper and faster, so there's really no advantage with that. And looking at fixation of other prolapsing structures, they can be treated alongside this method. It avoids complications associated with rectal mobilization and resection. Biological meshes have significantly reduced mesh-related complications, as we know that meshes and pelvic floor surgery has been a public health issue recently. But on functional outcomes, the literature has been a bit ambiguous. Bladder function, sexual function, bowel function, and the symptomatology that follows each of those has been reported with different outcomes. So there's a need to assess functional outcomes following this procedure, and we've put together a quantitative retrospective cohort study which has been completed actually now, and the manuscript has been submitted to BJS and is being reviewed for publication. A questionnaire was used, and it was used to collect information from patients pre-operatively, look at their quality of life, and then post-operatively, and then to see if there was any improvement. Thank you.
Okay, that's very interesting, and especially what you're doing next. You mentioned the media kind of coverage of mesh in gynecological prolapse repair. Cause the concern there is of chronic pain. did you find any issues with chronic pain in the mesh rectopexy?
No.
Or any
Regards
other techniques?
Yeah, with regards to pain with rectal prolapse, no, there wasn't any problems with that. With regards to pain in terms of bladder problems, there wasn't any difference pre-operatively compared to post-operatively as well.
Okay.
Okay, there are no further questions. So next we've got, I think this is the last one, Elaine Yeep, who's going to talk to us about barium defecating proctography, her experience from a tertiary referral centre. Over to you, Elaine. Do we have Elaine? Turn your microphone on if you have.
Can you hear me?
Yeah.
We can hear you.
Hi, good evening, and I'm Elaine. I'm one of the surgical registrars from west of Scotland, and today I'll be presenting barium defecating proctography, an experience from a tertiary referral centre. So pelvic floor dysfunction, or PFD, is a major healthcare problem affecting the elderly and at least a third of the female adult population. And symptoms of PFD can cause major impediments on the quality of life and is a recognized important aspect in women's health care needs. And imaging such as BDP is frequently used to assess in the assessment of patients with PFD. So we conducted a retrospective audit of patients who underwent barium defecating proctography, and they were identified from a computerized radiology information system. And data regarding those who had surgery was retrieved from the anonymized West of Scotland patient registry called Safe Haven. So the results, between 2000 and 2014, 671 patients were identified. And looking at table 1, a majority of patients were female with a median age of 51 years. Most of these referrals were from gynecology, which makes up 74%. And the main symptoms investigated were obstructed or incomplete defecation or chronic constipation. 12.4% had previous surgery for PFD. Looking at table 2 and 3, just a wee summary, normal defecation was seen in about 74 patients, which is 11%, and complete barium evacuation was observed in a vast majority, which is 70%, or 467 patients. 116 were noted to have incomplete evacuation, and up to 81 patients had no evacuation, but that only makes up 13%. And rectocele was present in half of the patients, out of which 67% were large and moderate size. However, there was no significant association between any of the presenting symptoms and the presence of a rectocele. Looking at table 4 below, only 12% patients underwent subsequent surgery. A total of 100 procedures were performed. And table 4 shows a breakdown of all the procedures and their specialty. And majority of the procedures were done under the colorectal specialty. Of the 78 patients who underwent surgery, 17 patients underwent life-changing multiple operations, and of these, 3 of them ended up with a permanent stoma. And figure 1 here shows most operations were undertaken by a single specialty, and only 1 patient had procedures done by 3 specialties. And in conclusion, BDP contributes to decision-making in patients with pelvic floor dysfunction. However, the results need to be interpreted with caution and in conjunction with other tests and clinical examination in order to reduce the risk of adverse outcomes in these patients. Thank you.
Thank you very much. Question from Professor Anderson. Could you tell if the use of this test has increased, decreased, or stayed the same over the last few years?
At the moment, I think from our results, it seems that it's been roughly the same. There's still quite a lot of BDP requests through.
Okay. Any other questions? I'm a HPV surgeon, so I don't look at many barium difficating proctograms. If 70% of them are are normal, what's the main thing that makes you want to progress to surgery for pelvic floor dysfunction?
So I think this all should be because BDP is only just one aspect of the investigation. So there are other tests that should be considered, and the gold standard should be run through now a pelvic floor MDT to actually decide who really needs this surgery, especially in Scotland, where since last year, 2018, the government has decided that we should stop particularly gynecology mesh-related surgery, including ventral mesh rectopexy, and since March last year, it's been extended as well.
Very good. If there are no further questions, I will bring this session to a close. I want to signpost you all to the e-posters, which are all available, and there are prizes for the best posters that are chosen by our execs. So I do urge you all to have a look at the e-posters, which the link is there. It's been a very interesting session. I think some of the presentations have been fantastic, and the topics very, very interesting. I want to also remind you that our next session is tomorrow. Again, this a general session. It will be moderated by myself and somebody else. I can't remember who's joining me tomorrow. Very well done to all the presenters and to the panelists, and I wish you a good evening.